Patient is happy, wandering around, wants to go home.
And I let them play some ABBA music in the room very quietly on the background, and I just perform my procedure.
So here we are back with the next episode of Endoscopy Essentials in the middle of the series of pancreatic fluid collections with Shyam Varadarajulu. Welcome back and thank you very much. So the next topic is necrosectomy. So we are pretty sure that there's necrotic material or it's just coming pus out and necrosis. So we have a WON walled off pancreatic necrosis. I'm not a fan of abbreviations, but necrotic tissue. What are the basic considerations?
When you drain a fluid collection, you always will have to determine prior to placing a stent how much of necrosis is there. If somebody has less than 20% necrosis, usually we don't have to do anything. It will just drain off through the stent.
By CT?
Yeah, by a CT scan. On the other hand, if you've got more than 20 or 30% necrosis, then it is very unlikely that all this necrosis will just miraculously disappear. What happens is these patients will have very good symptom relief by mechanical decompression. They'll feel a little good, and then you discharge them. And then there is secondary infection of the necrotic tissue, and they'll come back in another 2 or 3 weeks, or even earlier, and then you start doing your necrosectomy. So my golden rule is anybody with more than 20 to 25% necrosis, I watch them for a few days in the hospital, and I've got a protocol for it. I will do a CT scan at 72 hours. If there is no resolution of all clinical symptoms, primarily fever and a decrease in white count, and the fluid collection has not decreased by 25 to 30% in size, I will reintervene during that hospitalization, irrespective of how the patient looks. And then when you do your necrosectomy, there are a couple of things. Sometimes when you place a lumen-opposing stent, you can intervene directly. And these are patients who are morbidly sick. They've got 80 to 85% necrosis. They're in the ICU. They've got organ dysfunction. Just decompressing them is not enough. I would dilate the lumen of the stent, and I would go in and start my necrosectomy. And
during the first session?
During the first session.
In general anesthesia? For that
absolutely.
very reason? Because the patient is sick anyway?
Yeah, they are very sick. And generally these are patients in the ICU. And then I will start a treatment, and I will put some peroxide. And peroxide, what it does is it mobilizes the tissue for a subsequent session. But this is only about 10 to 15% of patients. A vast majority of them are not too sick in the ICU. In these patients, I will just place in a metal stent, and I will follow what I call the step-up approach, which at 72 hours, if you've got symptoms and the collection is not decreasing in size, then I'm going to go and intervene. So it's a very empiric thing for people to say, how does a patient look? I don't think it's a very objective way. I think we have to look for SIRS, all the 4 criteria. We have to look for sepsis. We have to monitor organ failure and their ability to take oral intake. And I think with the combination of these factors, we can determine how fast and how often we should reintervene. And my rule is always 72 hours. I always go back at 72 hours, and then I will repeat it as often as required.
But the biggest challenge, isn't it, is the patient who does clinically very well. The cyst decreases or the collection decreases in size, but there is still some, maybe it's 50% and stays at that level. And the radiologists say, oh, there could be some remaining necrotic material. Patient is happy, wandering around, wants to go home. So what do you do?
So
just wait? Let Mother Nature do the job, or?
Not actually. I think if I think people have different approaches to this problem. I usually will never intervene in the first place. If somebody is very good and if the cyst is, no matter how it looks, I don't intervene. But if after I place a metal stent and then the patient is feeling a little better and they're walking around, but the quantity of necrosis is significant, I generally try to treat them. I tell the patients, if there's a patient coming within a 20-mile radius, I don't have a problem discharging and letting that patient know and tell them, if you get sick, just come to the emergency room or call my office. But if the patient is coming 300 or 400 miles away, I get very cautious and I tell them, there's a very high chance this is going to require a reintervention. You're looking great. And maybe this is the time to do it, not when you're very, very sick. And I go after these patients quite aggressively, 3 or 4 days down the line, and I try to clean out. I don't wait to remove 100% of the necrotic material. It's almost impossible. But if I can remove 80 to 85%, I've got a huge patent tract that will spontaneously evacuate the residual contents. I'm quite happy with that.
The next question is almost a separate episode, but maybe you can briefly tell which accessories, which scope, what's your favorite approach?
Okay. So my favorite scope is a therapeutic gastroscope, not the double channel, a single channel. I always connect my scope to the water pump, to the water jet. I don't like flushing water jet. The best equipment to use is a snare.
Still?
Yes, snare. So it can be anywhere between 15 millimeters to 30 millimeter, depending on the size. You should have a cap at the tip of your scope because you can snare it, suck it into the cap, and you can mechanically evacuate it into the stomach. So those are the 3 basic accessories. If I need to use a forceps, I use what I call the Raptor forceps. It's about 18 millimeters in diameter, and it takes huge chunks of tissue. So between the snare and the Raptor grasper, the 1T scope, and the cap, I'm fairly self-sufficient.
Any fancy new devices or still experimental?
There are some new devices, some motorized devices that they say can swirl the cavity and can mechanically extract the tissue for removal at a later time. There's no randomized data, but some investigators seem to believe that it helps.
Sometimes it takes a long time with the snare. So you pull out little pieces and maybe after half an hour comes a big one and you're happy and gone. And
I have a rule of thumb, which is a 90-minute rule. So I always perform the procedure as the last case of the day. Always. I have a cup of coffee and then I come back at around 5 o'clock and I tell my staff, we'll be done at 6:30. And I let them play some ABBA music in the room very quietly on the background, and I just perform my procedure.
Another good thing we found out is exchange the physician after, 60 minutes. You have a cup of coffee and then come back.
Yeah, I think...
Just get tired, a little bit aggressive. Why doesn't it come out as a whole? And
sometimes if the material is very pasty, I think the color is, if you've got a black pasty material, it's not going to work. You can spend 5 hours. So in those cases, I think it's important to be prudent. I put peroxide to let it marinate for a while. I mix 3% peroxide and saline in a 1:3 ratio. I put in about 150 to 200 cc's and I just aspirate and I let the patient come back at 72 hours. It's much, much easier.
Yeah.
Pursuing with a thick, dense, pasty, black necrotic tissue doesn't help.
So 90 minutes, coffee, ABBA music.
That's it.
Okay, I get it. Good. So let's leave the necrosis at least for the time being. Our next topic we agreed on is recurrence prevention. So the cavity is empty, it looks good on CT. Anything left or just pull out? When is follow up? All these issues.
So I think when somebody comes with pancreatitis, it's just not the drainage and discharging. We have to look at 3 years down the line. Not having the patient come back to the hospital for the same problem is the definition of treatment success. So, and that has everything to do with the pancreatic duct. Now that the cavity is gone, all that we care about is the pancreatic duct because that is where the problem is. If there's a leak in the pancreatic duct, I will, at the 6-week time when they come for follow-up, I may do a ERCP. And if there's a leak, I will stent the pancreatic duct. That's one. If the duct is disconnected, then obviously I will exchange the metal stent for a double pigtail plastic stent so that you can drain the residual gland.
Forever or for how long?
Forever. I leave them straight. And I tell the patient it's possible that they're going to spontaneously pass it. But I never go back and remove the stent. And I tell the patient, if you're going to have an endoscopy for a different reason, for an acid reflux, please tell the gastroenterologist who's performing the procedure not to remove the stent. And the third is a pancreatic gastrostomy. I think that is the most difficult procedure in interventional EUS. So if I discharge and the patient comes to me with recurrent abdominal pain and I do a MRI and I see a progressive dilation of the pancreatic duct at the tail, then I painstakingly do a pancreatic gastrostomy with a 7 French single pigtail stent, and it almost always gives adequate symptom relief for the patient.
And this cannot be predicted at the time where you still have your access after removing the stent?
No, unfortunately it is not, because very often these are not patients that we have seen. These are patients who have been to a different facility, has been treated, and they come back to you in 2-3 years and you see it. And you also occasionally see it after a Whipple procedure. Patients have pain and then you've got this progressive dilation of the pancreatic duct. And I think pancreatic gastrostomy is a good technique for these patients.
So that would be follow-up, right?
Yes.
And there's one follow-up when routinely, the first one.
So the
Patient
routine
is fine.
Routine follow-up is always at 6 weeks.
6 weeks.
6 weeks, 4 to 6 weeks, because we know that you leave a stent beyond the time, it can cause complications. So 4 to 6 weeks, I remove the metal stent, I do a follow-up. And we've got a very good research team. They will call the patient at 3 months and at 6 months. And we catalog those follow-up phone calls from those patients. And when there's a problem, we will bring them for an endoscopy or we bring them to the clinic and talk to them. And the complete follow-up ends at 6 months before we close it off.
Okay, but almost every time you have a good cross-sectional imaging in addition to your US and whatever you do endoscopically?
At the 6th week follow-up, cross-sectional imaging stops. And at 3 months and 6 months, if the patient is asymptomatic, nothing is done. But if they tell the research coordinator that they have got symptoms, then they go for a MRI or a CT scan.
So symptoms or lab? Normal lab, like leukocytosis, still CRP of 50 or...
Usually when you make a phone call, it's usually the symptoms that you get. Labs is when they land up in an emergency room randomly somewhere. And they call and tell us, hey, listen, you got an old patient of yours in our emergency room, and the patient is sick, and we got a CT scan, and the white cell count is high. We almost always transfer them back to our facility.
Let's say everything is okay, lab is normal, patient has no symptoms, patient is young, like 40 years. Are you not concerned about long term if you don't know?
Yes.
That
these patients have now developed chronic pancreatitis. I mean, on the residual gland, they've got a disconnected gland, or they've developed chronic pancreatitis, and they become your patient. So we have a medical pancreatologist who just deals with these patients. Then you do a lot of small things. There are some antioxidants, and there are some vitamins, C and E, and methionine and selenium. Data has shown that it helps these patients. We don't fat restrict them because these patients will develop malnutrition. So I tell them, as long as you don't smoke and as long as you don't drink, please feel free to eat what you want. Take these supplements. If they've got diarrhea and so on, we check for pancreatic insufficiency. If their diabetes is not under good control, we send them to an endocrinologist and a medical pancreatologist. So it's actually a comprehensive follow-up is involved, and they get a dietitian follow-up because some of them don't take good supplemental nutrition.
So you don't necessarily do an endoscopic or cross-sectional follow-up, but you follow the patient, right?
Yes, we follow the patient, correct.
And don't act according to what they have. But wouldn't be maybe after a year or two another imaging like MR or CT be good, or we just don't know?
You'll be very surprised. A lot of these patients have ongoing symptoms that we are not aware of. So whenever we treat these patients and we look at a 6-month follow-up, we feel so happy that we've got a 95% success rate. But actually, when you call those patients or their primary care doctors, you realize they've been going to the emergency room with some abdominal pain every 3 or 4 months. They've got residual symptoms and so on.
Okay.
A small fraction of patients, primarily from gallstone pancreatitis usually, that if you treat them, they do well for life. Those patients with other etiology like smoking or alcohol intake and other etiology and so on, they don't do very well. They continue to have morbidity. And there is some data, retrospective data to say that there's a higher mortality in these group of patients in the long term, not necessarily related to pancreatic disease, but to something else. So that's why I think calling patients gives you a sense of humility that we have not fixed everything endoscopically. While they may not have a collection of fluid, they have ongoing pancreatic type symptoms that adversely impacts quality of life.
Which at least a small fraction of which might be fixed endoscopically.
Those with, as we talked about, a dilated pancreatic duct with a stricture, we can fix them endoscopically. Other than that, and if there's a recurrence of fluid collection, we can retreat them. Other than that, there's not a lot we can do. Then that's where medical management comes to play.
So the message is, you might be very proud, the patient will come back anyway, but the risk is that he doesn't get to a specialized center. So people treat some pain and don't care so much. So some kind of follow-up, at least clinically, and then decide whether to call the patient in to the center would make a lot of sense.
I give them a very detailed instruction on discharge. We talk to them about, we know that celiac plexus block is not a perfect treatment for chronic pancreatitis, but we give them all these options. So if you develop chronic pancreatitis, this is what you do. This is your dietary needs so that you are not malnourished. These are your supplements that you take. You have an appointment with a pancreatology specialist. You have to go see your endocrinologist. And you give them a comprehensive information. Your educated patient is a good patient. But if you just treat their cyst and you just discharge them, it's not a good treatment option. They always come back.
Okay. It's also important to know, is there enough data on long term, let's say 2 to 5 years after a collection intervention?
Not actually. We have some follow-up data, about 3-year data, but those data are primarily related to reinterventions. I think what we woefully lack is the quality of life data on these patients, rehospitalization for abdominal pain, inability to hold on to a job, narcotic dependence, nutritional status of these patients. These are all information that we don't have.
So you have this working group, right? This pancreatic
study
working group, right? So maybe that's your next big study.
I think very well so. I mean, I think we can study a lot on these patients on their natural follow-up, and then we need to find out what can we do to improve this. I'm afraid that eventually it's going to be multidisciplinary management of these patients, which I think is important, still important.
Right, but I think it's a little bit short-sighted. We say, we solved your acute problem and you will never come back, which is a lie.
That is
the majority.
Absolutely true. Yeah. That is a lie.
Okay. Good. We have not touched one thing, is the percutaneous intervention, which is never, as I understood from the previous podcast, a primary thing.
That's true.
But sometimes you have to do it, you can't reach it, or you have to do it in addition. So what do you do? Is it just the same thing, dilating it and then going in? And
there are some nuances to your percutaneous necrosectomy. So we have to tell the radiologist, please access it from a point that is closest to the abdominal wall. Only because when you pass a gastroscope, you have to tunnel your way through the tissue and you have to dilate the tract. If you're going 18 or 19 centimeters deepen, and if you tend to deviate,
that's frightening.
It's very frightening. So that's one. 2, we have to ask them for the largest drain they can place. They will never place a 24 French drain on the first visit. They have to upsize the drain. So they'll place a 16 French and then upsize it to a 24 French. And it takes about 5 days for the tract to mature. And I think it becomes very important if a predominant part of the collection with the debris is located in a place that you can't access endoscopically. You have to do a percutaneous drain placement in these patients. And there are a couple of things that are important. So this is a classic video of how things look. So this is a 24 French drain that has been sutured. And what you do is, I will just walk through this video. You pass a guide wire through the drain, and under fluoroscopy, you coil that drain into that collection. You remove the drain and you can see a lot of necrotic material already coming out. Then you have someone hold on to the guide wire, and you should place a thick guide wire if you can, because it's a tough area to navigate. Now you dilate it. I usually prefer dilation to up to even 48 French, only because the skin is more thick than we can imagine. It's very, very tight. So you want to dilate the skin very carefully. So I go to 48 French. Because the tip of a gastroscope is about 12 to 13 millimeters. You need
So it's better than a big balloon?
It's much better than a big balloon.
Especially with regards to the skin entry.
Yeah. You have to go all the way down. It's not enough to just dilate the skin. You go all the way down. The skin is much, much thicker at the surface. So there you may have to use a balloon in addition, but you use a savory. And then you pass your gastroscope over a guide wire or alongside the guide wire. And once you go into the cavity, you start doing necrosectomy the standard fashion. In fact, it's much easier to do necrosectomy through the skin because it's just a direct route back and forth. And when you evacuate necrotic material, you can take it out of the scope externally and just re-intubate it. This should always be done only under general anesthesia. I don't think this is a procedure that can be done under propofol. And the things are, to be conscious about the organs around. Sometimes you can see the kidney and the spleen and so on. It's very important to be careful that we are not misconstruing these organs for a necrotic debris. Then it can be a big problem.
And CO2 is mandatory.
CO2 is mandatory. Irrigation is good. Constantly lavaging it is good. And then I end my procedure always with a little bit of peroxide flush, and then you reinsert the drain, and then you suture it back.
Any concerns about spreading things into the entire abdominal cavity, starting with air and ending with?
There's always air after the procedure. There's always a little bit of air, so you always have to tell the radiologist that an intervention was performed. Otherwise, they will think there was a perforation. One thing that I would be very careful is when you flush peroxide, sometimes you can have leakage of peroxide outside the cavity, and that is excruciating pain for the patient. And when you do a scan, you will see air bubbles, and that will be thought that the cavity has been perforated and the patient will need surgery. Generally not. I think it's important to convey to the hospitalist, doctor managing the patient, and the radiologist that a peroxide was used, and unfortunately it has leaked, and that pain never gets better. Those patients will require a peritoneal washout.
Pooh.
They always need a washout.
So why not avoid it?
Peroxide is a necessary evil because it mobilizes tissue very well. And when you go back for your subsequent procedure, you can find nice organized necrotic chunks easier for evacuation.
But obviously those risks for some reason seem to be less with the transgastric approach, the endoscopic approach, than with the percutaneous, or we just don't
No,
know?
it's almost the same. The thing we don't see it is because not many people do percutaneous necrosectomy as a transgastric, but it can happen on both occasions.
And it's usually a more severe disease state anyway.
Yeah, when you do a percutaneous, it means that you're having a CT severity index of 8 or 10.
Okay, and then you try to limit it to one necrosectomy procedure, or is the same 90-minute rule applying here?
Well, sometimes you do 10 sessions of necrosectomy.
Ooh.
Yeah, sometimes 10. I've had, I think I might have done a few hundreds, and there are a few patients, I know them by name, maybe about 8 or 10, who might have had more than 8 or 9 sessions. But an average patient will require 2 to 3 sessions, an average.
Same for percutaneous?
Yes, it's only 2. Percutaneous is actually technically easier. The initial parts where you communicate well with the radiologist, and this is the reason that you should never put in a drain through an intercostal margin, then you can do this procedure. But it's technically much easier than endoscopic necrosectomy because the distance you travel is so less.
Okay, Shyam, we learned a lot. I'm sure we'll come back at a later stage with open questions also from our viewers, but I'm deeply grateful. Thank you very, very much. It was a great pleasure.
Pleasure. Thank you.